Hello, I'm David Carbone. I'm a thoracic medical oncologist and director of the James Thoracic Oncology Center at Ohio State University. And I'm very pleased to be here today at the 5th OncoBronco Conference in Cairo, Egypt, and especially pleased that the International Association of the Study of Lung Cancer is signing an agreement with the Egyptian Cancer Society today in a memorandum of understanding. I gave a lecture today to describe the selection of chemotherapy versus chemo-immunotherapy versus immunotherapy for non-small cell lung cancer. Immunotherapy really is the basis of treatment of driver-negative non-small cell lung cancer right now, and one of the only biomarkers we have to decide on how to give this immunotherapy is the PD-L1 level. And PD-L1 high patients often are given pembro or cemiplimab or atezolizumab monotherapy, but not everyone responds in that group, and we sometimes wonder whether adding chemotherapy may help. Some real-world data show that there's an early drop in survival in patients treated with pembro monotherapy that didn't happen with the pembro chemo treated patients. So there's some early improvement in survival, but the long-term survival, if you take high PD-L1 greater than 50% patients, the long-term survival is pretty similar for both pembro chemo and pembro monotherapy. So but are there subsets of patients where you might pick one or the other? And it's very clear that patients with very high PD-L1 tumors do extremely well on IO monotherapy, but the fact is they still don't have 100% survival, so there's still room for improvement in those patients. So potentially we need other biomarkers to help pick these patients for different therapies, and we need new combination therapies based on individual patient and tumor characteristics to help improve on those numbers. One thing that came up in the discussion was the fact that in almost every study, even with a high PD-L1 tumor, never smokers often don't benefit as much from IO monotherapy as from IO chemo. So I think most people would agree that a never smoker should be treated with the IO chemo combination. The thing that may reflect actually is the tumor mutation burden, that patients who are smokers have a higher number of neoantigens and mutations in their tumors, so they don't need the chemotherapy. And that actually was supported by a study we did with Foundation Medicine, showing that even in intermediate PD-L1 patients, that patients with intermediate 1 to 49 PD-L1, but a very high tumor mutation burden, benefit just as well from IO monotherapy as the high PD-L1 patients. But in general, this question can be answered, hopefully, in the prospective trial called INSIGNA, which randomized patients with tumors greater than 1% PD-L1 to pembro monotherapy versus pembro chemo. And then, very interestingly, if a patient was randomized to pembro monotherapy, they were again randomized at progression to pembro continuing the immunotherapy and adding chemo or switching to chemo. So one potential way to solve this problem is to start these patients on IO monotherapy. If they do well, great. But if they progress on the IO monotherapy, add the chemotherapy, and we have patients in that arm that are doing very well with a durable second response and durable benefit with adding chemotherapy to the immunotherapy at progression. So in summary, I think we really still are learning how to best modify the immunotherapy regimens for a particular patient. And while we're now apparently curing about 20% of our patients with immunotherapy, metastatic disease, there's still a lot of room for improvement going forward with combinations and better patient selection.
Don't forget to like, comment, share, and subscribe to OncoDaily on YouTube. Hit the bell icon to stay updated.